I've got 1 o'clock on my end, so let's get started. Hi everyone, and welcome today to this webinar on the impact of SafeTALK Training on suicide prevention and a culture of health and safety in Niagara. My name is Sarah Webster. I'm a knowledge broker with Niagara Connects. Also from the Niagara Connects team today, we've got Lynn Johnstone as well as Mary Wiley on the phone. And we're excited for those of you who haven't participated in a webinar with us before. I'll give you a quick overview of the technology. So you're hearing my voice through the phone, and this is how you'll hear the presenters speak during the presentation. As well, you're in the online meeting room, and you'll see the slides on your screen move as we move through the content in our presentation today. You don't have to do anything to see the slides other than just be in the online meeting room. Down the left-hand side of your screen, we call that the chat pod, and feel free to type in any questions or comments during the presentation. While the presenters are speaking, all of the participant lines are muted, and that's just to help us cut down on background distractions of dogs barking and fire alarms and PA systems, and also to allow those who have joined in small groups to be able to have discussions as well in your space as needed. So the lines are muted, but you can of course use that chat pod down the left. And we will have an opportunity after the presentation in the last half of the call to have some discussion, and we can unmute lines at that point. In addition, this webinar is being recorded as we record all of our webinars through Niagara Connects. And the webinar recording, a link to that, as well as a PDF of the slides will be made available to you within about a week. We'll send you a link to those items, and we certainly encourage you to forward that on to any other colleagues who maybe couldn't join us today. So in terms of a quick agenda about what's going to happen today, this webinar actually came out and is linked to the community-driven launch of the Niagara Mental Health and Addictions Charter that was launched last May in 2014. And in November last year, the implementation phase began, and participants identified 7 focus areas to help move ahead implementation of the charter. And one of those focus areas or action areas was to link with and help move ahead the work of the Niagara Suicide Prevention Coalition. So the webinar today, we're going to hear about the work of this network and some outcomes of some evaluation efforts that have been done related to SafeTALK training. So as presenters today, we've got Lynn Johnstone from the Distress Center Niagara, Cino from Niagara Region Public Health, Sinead McElhone from Niagara Region Public Health, and unfortunately we are not able to be joined by John Kraskowski today from Public Health, but Sinead will certainly be speaking to the slides just as well as he was going to that piece of it. So I'm going to now turn it over to Lynn and Katie to take us away. And we'll have about half an hour, 40 minutes of presentation time, and then, as I say, we'll have time for a discussion at the end.
Okay. Well, thank you everyone for joining us this afternoon. It's much appreciated. So Katie and I are going to talk about the next few slides as it focuses on the background of the evaluation, the intention of the SafeTALK program, and the larger link to the coalition. Let me see if I can get this up here.
Click twice.
Here we go. All right, so I do think it's important to note before I start talking about the severity of suicide in Niagara is to say that my colleagues presented a webinar back in January, and it was called Making Niagara a Suicide Safer Community. And in that webinar, they talked at length about the impact of suicide in Niagara. So I would highly recommend it. So if anyone is interested, they can visit the archives on the Niagara Connects website to learn more. Okay, so to start with the presentation, let's take a look at some of the national and regional statistics. So in 2011, 3,728 died by suicide in Canada. And that's approximately 1,185 people in Ontario died by suicide each year. Now, men are 3 times more likely to die by suicide due to the more lethal means used, where females are actually 3 times more likely to act on their thoughts than males. If we take a look at our local statistics, we know that approximately 44 people die by suicide in Niagara each year, which is 1 death every 8 days. And when a study was conducted in 2011, it was discovered that 10% of the students in Niagara have seriously considered suicide. So we know it's a serious issue, and that's why we knew SafeTALK was needed in our community.
So we wanted to take a moment to speak to the Niagara Suicide Prevention Coalition, as they were directly involved in this evaluation. So you can see their mandate on the slide, but to share a little bit about the coalition, it was formed in 2003 and now includes over 25 agencies. The coalition is committed to suicide prevention, intervention, as well as postvention, and it really focuses on building strong community partnerships. The coalition often connects people to community services, but I think it's important to note that the coalition does not provide direct service itself. A regional strategy was released in 2006, which identified goals and objectives to support creating a suicide-safer Niagara. And Dee Tyler from Coast is currently the chair of the NSPC.
Okay, thanks, Kitty. So let me explain a little bit about the SafeTALK program. It was designed by Living Works out in Calgary, and its purpose is to bring suicide awareness out in the open so that anyone can recognize those who may have thoughts of suicide. And the goal really is to reduce the stigma and the myths surrounding suicide by discussing the tendencies to miss, dismiss, or avoid thoughts of suicide. And all this is done by applying the TALK steps, which is tell, ask, listen, and keep safe. And the idea is to then connect a person with thoughts of suicide to a suicide intervention caregiver. Now, these caregivers are highlighted in the community so that each participants are aware of who they are and how to contact them. I do want to mention that most the suicide intervention caregivers are ASSIST trained, but I will certainly discuss that more in detail in the conclusion of today's webinar.
So utilizing SafeTALK in Niagara. Before the Niagara Suicide Prevention Coalition and the Distress Centre started to offer SafeTALK in Niagara, some background work had already been conducted in order to assess Niagara residents' level of readiness to receive suicide prevention messaging. So specifically in 2011, a region-wide study was carried out, and these results showed that Niagara residents were in fact ready and would benefit from suicide awareness programs. Key results also indicated that there were sex differences in how residents perceive and respond to suicide. So males having significantly more negative attitudes about suicide compared to females. So to speak to the second point on the slide, SafeTALK training has been shown to be effective in teaching practical skills that are needed for someone to respond to an individual who is having thoughts of suicide. We also know that awareness programs, interactive workshops, and other preventative measures can really help to reduce the stigma that's often associated with suicide. And finally, we hope to utilize the effectiveness of SafeTALK as a way to encourage workplaces to incorporate this training into their overall health and safety policies. So with regards to the actual SafeTALK evaluation, this opportunity happened in 2014 when the Distress Centre, in partnership with the NSPC, obtained a $10,000 grant from the Niagara Community Fund in order to roll out SafeTALK training to both professional and lay groups in Niagara. And in total, 500 people were trained through this evaluation. Key groups who participated in the SafeTALK evaluation were EMS, Niagara Regional Police, and additional voluntary groups in the community. One requirement of this evaluation was that participants needed to be over the age of 18 in order to participate in the SafeTALK training. So typically, for a standard SafeTALK training, the Living Works requirement is that the participants be over the age of 15. But for this evaluation, again, we required participants to be over the age of 18, and females had to be between the ages of 18 and 34. And these age groups were based on the 2011 report that I mentioned in the previous slide. The main objective of this evaluation was to improve knowledge, skills, and attitudes towards suicide. And this was done by first implementing SafeTALK training for individuals who wanted to prevent suicide. So, for example, volunteer groups, again, EMS, Niagara Regional Police, frontline workers, and parents are to name a few. And secondly, by increasing awareness and comfort levels for people to discuss suicide.
Okay, so to explain the methods used in the evaluation, we started with 500 participants in the community, as Katie had mentioned. But before the SafeTALK training began, we handed out a pre-SafeTALK questionnaire, which we'll talk in more depth in the next few slides. And out of the 500 participants, 486 completed the questionnaire entirely. So meaning if there was missing data, then unfortunately they were not counted in the total. After the pre-SafeTALK questionnaire was handed in to the facilitators, the 3-hour SafeTALK training went underway. Now immediately after the training, the facilitators would then hand out a post-SafeTALK questionnaire. And out of the 500 participants, 317 completed the questionnaire completely. And lastly, with the participants' permission, we either contacted them by phone or by email for a 3-month follow-up, and 34 participants completed the 3-month follow-up. So one of the questions asked in the pre-SafeTALK questionnaire was if they had past or prior suicide risk training. So 48% said they actually had no training at all, 26% said they had previously had 1 to 3 hours, 15% said they had previously had 1 to 2 days, and 11% said they took a longer course.
So as you can see with this slide, the largest part of the graph is represented by other, and this is because other represents EMS staff. So over 250 EMS staff participated in the training through this evaluation. The Distress Center is the lead organization for suicide prevention in Niagara, and they now have a partnership with EMS to train all of their new recruits in SafeTALK. And we'll speak to specific feedback from EMS and other groups in later slides. So I'm now going to turn it over to our colleague Sinead from Public Health, who will speak to the data analysis and results of the SafeTALK evaluation.
Okay, thank you very much, Katie. My name is Sinead McElhone, and I'm the manager here for surveillance and evaluation. And I was involved in this SafeTALK evaluation project from the outset. So as was mentioned previously, participants were handed out a variety of questionnaires, certainly 2 sets of questionnaires, one before and one after the SafeTALK training. So the majority of participants, almost half of them, had already talked openly about suicide on more than 20 occasions, but this actually may reflect the fact that we had a lot of EMS or police who undertook this course. However, 1 in 8 had never talked about suicide, and almost 1/10 had only had that conversation once. So, as a result of undertaking SafeTALK, participants were asked, how prepared do you feel to talk directly and openly to a person about their thoughts of suicide? So as a result of undertaking SafeTALK, participants then were more likely to say that they felt well or mostly prepared to talk to a person about their thoughts of suicide. And this is quite good actually, because it reflects the actual the aims and objectives of the SafeTALK training. So you can see there, before the SafeTALK training, most participants had said they would be partially prepared to talk about suicide. But after the SafeTALK training, you can see that the main percentage there was had moved to the well prepared. Next slide, please. So in this slide, just to give you a little bit of background, participants were asked their level of agreement with a variety of statements related to suicide. So this was pre and post their training, or before and after their training. I'd also like to point out that all of these questions which we included in the questionnaires, they were questions which we had obtained from other surveys and other studies which had utilized SafeTALK, which had evaluated SafeTALK across the world. So we looked at some studies which are carried out in Australia, in Scotland, and I think in the US, I think. And so we looked at their questions, and then we incorporated those ones into our questionnaire. So the majority of the results here went in the expected direction. So i.e., or that is, after the training, more people believe that suicides can or could be prevented, and people who were suicidal gave signs that they wanted to die. However, you can see here from these two charts that some of the biggest changes in beliefs and attitudes were those aged 40 plus for question 1, which is, I think, most suicides can be prevented. And also, there was another kind of large change as well here between, I think that people who are suicidal give signs they want to die, again, in the 40 plus age group and also in males. So that was quite interesting as well. Next slide, please. So again, participants were also asked their level of agreement with these suicide-related statements. So if somebody mentioned suicide, they were thinking of suicide, I would A, convince them life wasn't so bad, B, keep it to myself, or C, not take that comment seriously. So in accordance with the SafeTALK teachings, many participants, having undertaken the SafeTALK training, would now refrain from convincing people that life wasn't so bad. Although it is still interesting to note that approximately a third of participants would try to convince people that life wasn't so bad, and this is not in line with SafeTALK teachings. So again, there's some barriers there to kind of understanding why this was or was not very important. So if someone mentioned to a participant that they were thinking of keeping or thinking of suicide, those who would keep it to themselves decreased pre versus post. I mean, these numbers are very small anyway, but you can see the largest decrease was observed for males, dropping from 10% who said they would keep it to themselves before the training, right down to about 2% after the training. So those numbers are quite small. So again, for those two aspects of it, the results went in the expected direction. The not take the comment seriously, there was something unusual about in relation to this question, because it went in the unexpected direction. And again, perhaps it was the way the question was worded, or perhaps the question was not worded appropriately in the questionnaire. So again, I mean, if there's any more research to be done on this, that's something that I would delve into in more detail. Next slide, please. So really, I suppose one of the take-home messages from this, the pre and post comparisons, and this is the same slide, or the same bar chart as before. It's just to reiterate that SafeTALK participants were more prepared to talk directly and openly to a person about their thoughts of suicide. So this definitely fulfilled the aims of the SafeTALK training. Okay, so, and you can see, yeah, thank you very much. Next slide. Okay, so this was just some questions that were specifically included in the post questionnaire, so the post-training questionnaires only. And this was in relation to confidence to deal with situations involving suicide. So participants were asked post-training their intentions regarding applying the SafeTALK training to appropriate situations. So on average, 80% of participants stated they would recognize the signs inviting help. And these were highest in the female and the 40 plus age groups. 3/4 of those would approach a person with thoughts of suicide, again highest in the females, and asked directly about thoughts of suicide, and again this was highest in the females. And also 82% would connect a person with thoughts of suicide to someone who could help and keep them safe. So again, these are all very interesting and obviously have, go in the expected direction. But I suppose one thing again from a critical perspective, is it not surprising that perhaps not all of these are 100%? So I would like, again, if there is any more research to be done on this, I would like to examine this further and just to see as to why do people still not have the confidence to deal with situations having undertaken the SafeTALK training. So you can see that the majority of people do. Okay, so 80% at least, 75 to 80% feel far more confident having attended the SafeTALK training. But again, there is that 20 to 25% who perhaps still are not as confident, even having taken the SafeTALK training. So again, it raises just some questions. So that is, I think, the end of the quantitative data. So if we move on to the next slide now, please. we're going to discuss some of the qualitative feedback as well, because within the questionnaires they had quantitative data, which was the data taken on numbers and percentages, proportions, and then there's obviously the qualitative feedback we obtained as well, which is people giving ideas of their thoughts and feelings and writing how they felt about various aspects of the SafeTALK training. So this qualitative feedback was broken down based on, I did a very, very basic theming and found that it kind of separated, the feedback separated into two distinct areas, and that was the delivery of the SafeTALK training and the content of the SafeTALK training. Next slide, please. So, with regards to the delivery of the SafeTALK training, these were just some of the general themes and the feedback in relation to this, and again, very useful for sending back constructive criticism, I suppose, to those who actually developed the SafeTALK training. So you can see there that, general consensus was that 1 or 2 breaks, a shorter session, or perhaps a more upbeat approach. Again, this idea that SafeTALK is better for younger age groups, that seemed to be throughout a lot of the results. Again, need an online version of SafeTALK, which was, again, some other really useful feedback. And again, the idea that SafeTALK is recommended for lay groups and make it more accessible to these groups with regards to the delivery of SafeTALK. And again, some people absolutely hated the role-playing scenarios, while some people really liked them. So again, you can see that there's split opinions on the videos and the co-trainers. Some people rathered or preferred more role-playing and acting out scenarios, whereas others absolutely didn't want that. So you're going to get that with any kind of training that's delivered. But a very useful idea was perhaps someone in to talk about their experiences of using SafeTALK. So again, this was some really, really useful qualitative feedback, which definitely can help within the future deliveries of the SafeTALK. Next slide, please. Okay, so this is qualitative feedback on the SafeTALK content, so the actual content of the material. And again, there's some quite useful, quite practical feedback and some statements there. So some people wanted more information on what to do next, because they really enjoyed the SafeTALK training, they found it really useful, and they wanted to know what was the next natural step that they could do, for example, assist training. There was a lot of comments in relation to the fact that the content needs to be tailored to the specific audience, and that it really wasn't, it's not really a one-size-fits-all. You can't be delivering this kind of program to lay groups and to professionals, because they come to this training with such different backgrounds, or in this particular training anyway. Perhaps a better discussion of barriers to talking about suicide. Again, the idea of use of real-life successes, accounts, and testimonies of actual people. And some of the health professionals, you can read the rest from there, but again, some of the health professionals cited, and again, I think this is reflective of the high proportion of EMS participants or who undertook this course, that it was just too basic for their needs, although some did say it was a great refresher. And then, of course, we also have the people who say, don't change anything, it's great the way that it is. So definitely, I think the take-home message from this is that the content of SafeTALK needs to be tailored to the specific audience. Next slide, please. So, as was mentioned previously, approximately 100 individuals provided contact details, which allowed us to contact them via email after 3 months after they carried out the SafeTALK training. So some people elected to complete an online survey, there's about 34 of them, and then some elected to complete an actual telephone interview, so there's 15 of them. So although these numbers might seem quite small, actually, in the Scottish study as well, when they did an evaluation of their SafeTALK, they had about an 11% response rate, and that's similar to what we have. We had about 10% of people who undertook the 10% of the 500 people, which is about 50 people, they elected to undertake further evaluation. So this appears to be quite normal. So of those who 34 completed the online survey, and 46 were male, and more than half of respondents were in the 18 to 34-year-old age category. So that was all the younger participants, which is quite interesting. So the great majority of these felt that the SafeTALK training was useful and that the objectives were met. So the main objectives of the SafeTALK training were 1, to identify persons with thoughts of suicide, and 2, to connect persons with thoughts of suicide to suicide intervention caregivers. Okay, so the young people who had completed this felt that the objectives of SafeTALK training were met. And what's really useful or kind of was that more than half of this particular group had used the SafeTALK, which is the tell, the ask, the listen, and the keep safe since the training. So they're actually putting what they've learned into practice. So that's actually a really good take-home message. More than half of this group felt well prepared in terms of talking directly and openly to a person about their thoughts of suicide, and no one felt unprepared. So some quite useful results there that we obtained from that 3-month post-training results. Next slide, please. So again, as with the pre and the post, the original pre and post questionnaires, which were handed out to participants on the day, which had both a quantitative and a qualitative aspect, the 3-month post-training results also had a quantitative and a qualitative aspect. So when participants were asked what was, now that they had used SafeTALK, now that they had 3 months to use it and to think about it and to reflect on it, what was the most useful aspect of SafeTALK? So I have to say, with these participants, the comments were mainly positive in nature, and they were mainly in relation to an increased knowledge of the burden of suicide in societies, and an acknowledgement of the fact that it made them more understanding of suicidal persons and felt more empowered in dealing with people who were suicidal. So what they really enjoyed, what they really liked, was that structured and specific response to a situation, which were the SafeTALK steps. And they also liked the videos and the role-playing. So I suppose, having undertaken the course and having applied their knowledge, they now realised that the videos and the role-playing were actually quite useful and quite important. And also, as with regards to who do they refer people onto, the Distress Centre and Coast were most referenced in this for this. Next slide, please. So as with anything, we asked about the positives and the negatives of the SafeTALK training, because that really helps with the kind of constructive and the criticism of SafeTALK as it is, and can really help with moving a training like this forward. So some people, or one person, identified the inability to help the individual beyond just connecting them with a resource. They said a de-escalation method would have been used. And then there's some more practical ones, like the initial few pages of the SafeTALK resource book could have been formatted in a more easy to follow way, and that was reflected as well in some other information. The length of training or outdated videos, again, that was kind of picked up as well in the original training evaluation, and also that there was a lot of information given in a very short period of time. So, and there was one person who made a comment in relation to the fact that there was not much knowledge on current communication methods such as texting. And I thought that was quite interesting, because I have to say here, this is very anecdotal now, but just to let you know that certainly I'm aware that our SDOH nurses or outreach nurses here do use texting as a means of getting in touch with their very hard to reach clients. So that's certainly something that could potentially be explored over the coming years. Next slide, please. So 15 telephone interviews were held, and these interviews took approximately, I think, 20 to 30 minutes, and we obtained a great deal of information from these telephone interviews. So all of those who took part in these telephone interviews felt that the objectives of the SafeTALK trainings were met. So when we asked them, for the SafeTALK objective 1, which is to identify persons with thoughts of suicide, the quotes included that they became comfortable in speaking to people about serious issues and asking them about thoughts of suicide. They provided examples on how a person may say they are suicidal without saying the actual words. Again, this idea of a great refresher course, and that it provided clues and hints to look for when somebody is having thoughts of suicide. And again, other comments are related to the fact that again, people really felt that this training was great for the average community member, or for those who had very, very little knowledge of suicide and mental health. Next slide, please. SafeTALK Objective 2 was to connect persons with thoughts of suicide to suicide intervention caregivers. And again, I know this is just one quote, but again, this is reflected in some others, individuals or participants who took part in these telephone interviews. But I thought this was just a very nice all-encompassing quote, and it was the emphasis on dealing with the immediate crisis and then passing them on to an assist-trained individual or other trained individuals. And the emphasis is on not being able to solve the entire problem immediately, nor is it your responsibility. And again, that I thought was a really nice kind of quote, and fits in exactly with the objectives of the whole SafeTALK training. Although from a negative perspective, one individual did state that the system is convoluted and difficult to navigate, and this particular individual had said that we've seen too many times that connecting to caregivers has proven ineffective. So obviously there must be some sort of disconnects there within the actual system. But again, I'm sure you will know more about this than I do. But again, so if we just move on to the next slide, please. So with regards to the telephone interviews, again, what did you think were the most useful aspects of SafeTALK? And again, it was this idea of the application of the talk, these clear steps that anyone could learn and could utilize, which are very practical and very easy to learn and to use. They liked the good working template, and also they liked the openness and mindfulness around talking about suicide. And that increased their comfort level, and they liked the videos of the real stories. And some people, like the people here, had identified that they really enjoyed the role play, and that they found it an excellent refresher course and an interactive workshop. So respondents did state that they became more sensitive and compassionate to the issue, and were not as likely to dismiss somebody with thoughts of suicide. So as I note, I'm coming up actually to the end of my slides and the end of my time, and I think I am on time. I would certainly say from a research perspective, we learned a great deal, or I certainly learned a great deal from carrying out this evaluation. So, yeah, and I suppose if I were to do this again, I would certainly do some things differently. So the report actually contains more information on the methods and the strengths and limitations of this piece of research, if anyone is interested to explore this further. So now I think I am handing it back over to Lynn, as she's going to discuss or talk about the conclusions.
Thanks, Sinead. So as we come to the conclusion, the report found that the participants believed that SafeTALK training was useful and practical, which was great news. And the majority felt prepared to openly ask an individual about their thoughts of suicide, which we know the best way to prevent suicide is to have that open and direct conversation and dialogue. The qualitative feedback showed that SafeTALK was most useful, as Sinead said, for laypersons, volunteers with no health background, and young people. And it was least useful for experienced health professionals who dealt with crisis mental health situations more on a regular basis. But for these individuals who had more experience, we would definitely recommend the ASSIST program that I spoke about at the start of the webinar. And ASSIST stands for Applied Suicide Intervention Skills Training. So Sinead said sometimes people wanted that natural step after they finished the SafeTALK, and the ASSIST would be that great next step. Because ASSIST is another program developed by LivingWorks, but its focus is learning these suicide intervention skills over a 2-day workshop. Now, ASSIST workshop is offered, if anyone is interested, every couple months at Distress Center. You can certainly visit the website, www.distresscenterniagara.com, for more dates and details. And lastly, if anyone's interested in reading the full report, please see the hyperlink at the end of our presentation.
Okay, so where do we go from here? So first, we would like to encourage workplaces in Niagara to include SafeTALK as part of their ongoing health and safety training. The Niagara Suicide Prevention Coalition does have a specific working group focusing on this, and there is a larger communication plan linked to this initiative. So ideally, we're advocating for SafeTALK to be promoted as a standard of practice, so similar to that of CPR or first aid. There are various trainers in Niagara. 10 were trained through the coalition, so each representing diverse agencies. Also, the Coalition is working towards fostering a community of practice for all SafeTALK trainers, so we can come together, share our knowledge and experiences with each other. Anyone interested in booking a SafeTALK should connect directly with the Distress Center. And a key goal of the Coalition is to have as many people as possible trained in SafeTALK. And we're proud to share that over 600 people were trained in Niagara last year. So to conclude our webinar, we wanted to remind everyone of the Distress Center's annual Suicide Prevention Walk on Sunday, September the 13th. They are welcoming all to come out to help draw attention to this very important cause, and of course to ultimately promote a suicide-safer Niagara. And I think that's it, and we could probably open it up for questions.
Absolutely, thank you. And I'm just going to flip here to show that there are some references that will be included with the slide deck. And as we move on to some discussions, I'll leave this contact slide up so people can take some information down. So this is the part where we kind of open it up to hear from you on the phone. I do see that we have some questions that have come in, and we'll address those at this point. And as well, if you have any questions for any of the presenters, you can either use the chat pod on the left to type in your questions, or you can unmute your phone by pressing *7. So let's start off. We have a question here regarding the results portion of the study. Were there any revelations noted related to cultural differences within the participants? For example, any participants who come from a culture where suicide might be viewed as taboo, any connection between that and the person feeling less confident in tackling this issue?
Okay, so that's a very good question, and no, we didn't, because we didn't ask people about their culture or ethnic backgrounds in the questionnaire, so that's a question we couldn't answer. But again, I mean, that's a very good idea.
Absolutely. Jamie asks, how has the SafeTALK training been adapted to respond to this feedback about content, or is that still in process?
It's a good question, Jamie. I probably should have mentioned as well that SafeTALK it's standardized, like I said, and it was created by Living Works out in Calgary, but it's worldwide, so it's international. So you can take SafeTALK in Korea or Norway or Sweden, and you'd be actually getting the same exact information. So it is important to note that at the end of any SafeTALK training, what they do is we hand out an evaluation form, so that Living Works always gets that evaluation feedback coming in so that they can make those changes. And I would say every couple of years they certainly take the feedback serious, and so they'll be updating videos, they'll be changing how they deliver the information, but based specifically on our report, the report will be sent to Living Works so that they have the information, but nothing has been corrected, because it's, as you can imagine, it'd be quite a lengthy process because there's thousands and thousands of trainers over, worldwide.
And we did invite a representative from Living Works to participate in the webinar as well.
Great. It's good to hear that there is a process for continuing to feed that information back up, because if that's happening, as you say, worldwide, that collection of feedback as well will then help to strengthen the program only more going forward. Perfect. Nicole asks, does or can assist be useful for someone who's not a health professional then?
Yeah, so assist can definitely be useful for someone who's not in the health profession. So anyone, again, as it was stated in the webinar, who's interested in knowing those next steps beyond SafeTALK should definitely consider taking the assist training.
And then piggybacking on that, there's a question about, can you kind of define a little bit further than the difference in content between SafeTALK and training? You've talked about SafeTALK kind of being that almost beginner level and then assist being the next step. Can you kind of elaborate then on the content differences?
Yeah, absolutely. So as you said, so SafeTALK is more the awareness surrounding suicide, getting people comfortable and open to talk about suicide, really tackling the taboo and the stigma, and getting people into the initial steps. So how do you notice? How can you identify if someone is having thoughts of suicide, and what do you do next, right? Where the assist training is, you're actually learning the intervention skills. So basically, someone who is taking the SafeTALK is almost passing off that individual to you as assist trained so that you can continue on with the intervention. So you're looking at the risk assessment, you're looking at safety planning. So it is much more in-depth because it's over a 2-day course, if that makes sense.
And you had talked about people being able to contact the Distress Center and that assist training is offered regularly. In terms of SafeTALK training then, if an organization wanted to pursue that and offer that to staff, what would be the process for that?
Well, actually, usually you would just send an email to myself, but since I'm on mat leave, you can certainly, if you do email Lynn at distresscenterniagara.com, it will certainly be forwarded to my coworkers. So you can contact us, let us know. Like I said, so we have SafeTALK and Assist, running year-wide. But if someone is an agency or frontline staff or a school is looking for a closed, like a private SafeTALK or Assist, they can certainly let us know, and we can come to your facility if that's more comfortable.
Great. And Mary asked, has the NSPC, the Niagara Suicide Prevention Coalition, considered connecting with service groups in the community to partner with them to promote SafeTALK training for their members and or for them to sponsor SafeTALK training sessions for targeted groups?
That's a good question. So I don't know if I'm understanding here correctly. So with NSPC, we certainly have SafeTALK trainers within our coalition, and those SafeTALK trainers certainly do promote. We're always looking and trying to target different populations who may benefit from SafeTALK training. So we're always trying to come up with different ways to promote it and reach different groups.
And the coalition actually does have a working group that is specific to SafeTALK. And so we do have a wider communication plan to sort of reach out to workplaces in Niagara in the hopes that they can incorporate SafeTALK training into their overall health and safety policies. That's sort of a longer-term goal for us.
So as Katie said, just like health and safety or CPR is part of people's standardized training, our goal, we would love for agencies to have SafeTALK as part of their mandatory training, just because anyone can be at risk of suicide.
For any participants on the phone that are maybe part of health and safety committees or anything within organizations, has this webinar sparked anything for you? Is anyone kind of thinking that this could be something that's implemented, or maybe what are some barriers to that even if you look within your own organization's health and safety culture and your mandates? And again, you can use the chat pod on the left there or verbally respond by pressing *7.
Hi, it's Vanessa from Niagara Region Public Health.
Hi, Vanessa.
Hi. I wanted to say well done, everybody. Really good job, because I know this is a tremendous amount of work. Speaking from our organization, we have been speaking with our health and safety. I think some workplaces, if you're looking at a way to align this with the new health and safety workplace standard under psychological standard, this would meet one of those requirements. It's not mandatory, but we are seeing a shift in workplaces starting to address psychological health. And as a standard coming from the Health and Safety Board, this would be one way to meet that, along with mental health first aid and other types of trainings. But this one, for sure, is a really good start to try to meet that standard, although voluntary. But if we're offering first aid, CPR, WMIS videos, how to wash hands, how to do modules on other related things, this would be right up there in terms of what should be promoted.
Great. And I do see here Lynn Purvis has responded saying, we're representing Positive Living Niagara, and we support those living with HIV and AIDS. We are going to approach the director about making this part of health and safety. Wonderful. That is exciting to hear. Thank you, Lynn.
I just have one more comment. It's Vanessa again. Not addressed from this survey, but I just wanted to give some feedback for anybody on the line that deals in targeting youth populations. We've had a number of youth take this training and have done focus groups outside of this survey to ask them about their experiences working with us at Niagara Region or out in the community. And the number one training that has come back from positive feedback that they will use in their life and throughout their life has been SafeTALK. So we had focus groups with a lot of youth, and they've said this was by far the best training that they have ever taken. They use it. They feel comfortable using it. They wish their parents had it. So there's some lots of feedback that's come from outside of this evaluation, but very positive feedback around SafeTALK.
Wow, that's fantastic. Thank you for that. Sandra asks here, please comment on the demographics of the participants who have been trained. I know that you had given some of the demographics at the beginning, and that was specific for this. Sandra, what additional information are you looking for maybe? Might be helpful. If you could just type it in the chat pod there. I'll give you a second on that.
So I can just comment a little bit around the age factor. So a requirement of Living Works for a standard SafeTALK training is that all participants be over the age of 15. But for this evaluation, participants had to be over the age of 18, and specifically females needed to be between the ages of 18 and 34.
And did you collect any information then about cultural background or ethnic background? I think I heard you'd say no, right?
Yeah, this is Sinead. No, we didn't, unfortunately, but that's because it was kind of beyond the remit of this study. This is more because of the nature of the people who were coming to this. We were very much focused on workplaces and where people worked and volunteered and all of that. But, you know, that would be a very useful next step, actually, to take a look at the actual demographics of people and find out, yeah, that would be, it's a very good idea. But it was beyond the scope of this particular project.
Right. But as you said, you've already got some things lined up for another time an evaluation like this would be done. You've already got some recommendations for what you might tweak another time, right, Sinead?
Oh yeah, absolutely, and that's the same with any research project. I mean, you do the research project and then you kind of reflect on what went well, what didn't go so well, and what you do differently next time. So yeah, and I think I've made those recommendations are incorporated within the main report. If anyone else is thinking about doing an evaluation of this kind.
Very helpful, thank you. Mary asks, is there maybe an opportunity to partner with HR leaders, example through companies that belong to the various chambers of commerce in Niagara, and or people teaching HR courses at Niagara College to see if they would be willing to pilot this training with HR students so that they can take increased awareness of SafeTALK training forward as they enter the workplace? Very interesting.
Yeah, I think that's a great suggestion, Mary. We're actually having our Niagara Suicide Prevention Coalition meeting next week, and we will be getting into our working group. So I think that that's definitely something that we can raise in the SafeTALK working group and continue to work towards that.
As we kind of let some final questions trickle in here, Sarah Johnston's going to start pulling up a couple evaluation polls on the screen. So for those of you in the meeting room, please just take a second and answer those, and those will help us continue to improve our webinars going forward. But in the meantime, are there any additional or final questions or comments for the speakers today? I did see Sarah has also put up in the chat pod there links for the training dates for upcoming Assistant SafeTALK training dates, as well as a link to the report that certainly Sinead's provided us with a lot of data from, but as she said, the report is much more full in terms of the context that's in there. So please do consider having a look at that and delving a little bit more deeply into this topic. And as well, there's the link up there for the upcoming Suicide Awareness Walk. So check that out as well. I also encourage you, for those who maybe heard about this webinar through a friend or through a colleague, at Niagara Connects we do host webinars regularly. And if you're interested in participating in something like this again, visit the Niagara Knowledge Exchange, and we'll put the link up. And at the bottom there's a button to get connected, and consider joining our electronic mailing list. And we'll send you the invitations for upcoming events like this directly, as well as our bi-monthly e-newsletter, which highlights resources, events, blogs, and new partners that have been added to the Niagara Knowledge Exchange. We've got a busy fall coming up, and in October we'll be hosting a webinar in partnership with the community health centers. And then in November, we have a webinar that we'll be hosting about mapping mental health crisis services in Niagara. So certainly another topic that would link into this, and certainly links back to the Mental Health and Addictions Charter as well. Mary just had a final comment here. Thanks for sharing this valuable information. We'll be sure to include highlights in the work of the implementation phase for the Niagara Mental Health and Addictions Charter. Absolutely. One final comment from Francis. Offering training for students is an excellent idea. What about Brock as well? Certainly.
So right now, Brock does not offer the SafeTALK training. They use QPR, and I believe, don't quote me, but I want to say it's a 1-hour training. But certainly we want to continue to try to build partnerships and relation with Brock, just like we do with Niagara College. Now, saying that, we did have quite a few Brock students join this this evaluation on their own merits. So hopefully we'll work at it, and we'll keep trying to build partnerships with them.
Great. Any final questions or comments from anyone on the phone? And again, *7 to unmute if you want to speak up. Okay. Well, we do have 2 more evaluation questions that will be coming up, so please do leave your screens open for a second. Stick with us for another minute or so. But in the meantime, I wanted to thank all of the participants. Thank you for joining us today and taking an hour out of your afternoon to participate in this webinar. And a big thank you to Lynn, Katie, and Sinead for your presentation today. You did a great job, and it was very informative and really helpful. Thank you very much. All right. We'll close it off there. We'll leave the meeting room open for a couple minutes for that last question. And other than that, have a wonderful day, everyone, and we'll be speaking with you soon. Thank you very much.